Welcome, everyone. Welcome to the panel on Meet the Social Innovators. SIHI is a global network of passionate individuals, organizations, and institutions advocating for social innovation in health and advancing research in social innovation. Today's panel, what we'd like to do is highlight what is social innovation? What is the concept? What is the SIHI network? And we'll dive into these questions and unpack them. We have a fantastic panel today. But before we get started, a brief introduction. My name is Joe Tucker, and I'll moderate the first part of today's session. I chair the board of SESH, Social Entrepreneurship to Spur Health. It's a group that aims to use social entrepreneurship to push forward health. And SESH is also a SIHI China hub. We're delighted to be a part of the SIHI family. And I would now like to introduce several house rules for today's Zoom meeting. If we could go to the second slide. The event will be recorded and archived on the SIHI website. So you can check us out at socialinnovation.org. Everything here is open and public. It's for attribution, nothing is confidential. Images from the event may be shared online. And for those of you who have low bandwidth or getting kicked out of the Zoom teleconference, you can check out the WhatsApp thread, or there's also a YouTube live stream. So, and importantly, put down your mobile phone, unless you're joining on the WhatsApp thread. Cull all of your open tabs and give us your full attention. We won't disappoint, I promise you. And there's also, if we have time, we'll be doing Q&A in between. There'll definitely be a chunk of time at the end just for questions. So I encourage everyone to put questions into the Q&A box on the Zoom chat. And when you do put questions in, ask or specify who it's to. So a question for Dr. Halpap, or a question for Francois, or whoever you'd like to ask the question to. That'll help us as we organize the questions. And now I would like to welcome Dr. Noel Juban. He co-leads the SIHI Secretariat, and he's a professor of epidemiology at the University of the Philippines, Manila, and also leads the SIHI Philippines group. So over to you, Dr. Juban, for some opening remarks.
That's too formal, Joe. Noel. It's Noel, guys. Good day to everyone. Welcome to today's webinar entitled Meet the Social Innovators. This is SIHI's second open line event for this year. The first one was about how social innovation plays a role in tackling health emergencies such as COVID, which we have experienced. And I hope you attended that one and learned from our panelists. Today, we are equally excited to present another opportunity to listen and interact with our social innovators and SIHI champions. We hope you are excited as we are. And for us at the SIHI Network, this is the third meeting where SIHI research hubs and current and invited partners are exploring points of collaboration. Do join the social innovation conversation by posting your questions here on Zoom and on our YouTube live stream. And again, we welcome everyone to this exciting learning opportunity. Back to you, Joe.
Thanks, Noel. Now I'd like to introduce Dr. Francois Bonici. Francois is a co-founder of SIHI and is now the head of the Schwab Foundation for Social Entrepreneurship, an important philanthropy and partner of SIHI. Francois also founded the Bertha Center for Social Innovation and Social Entrepreneurship at the University of Cape Town, which is the SIHI South Africa Research Hub. Over to you, Francois.
Joe, thank you so much for having me here, and hello to Noel as well. Lovely to see him. I think a warm welcome, firstly, to everyone dialing in and excited, and a special welcome to the social innovators who are going to be featured today. I mean, this is about their work, and I think both SIHI and my work has been really trying to learn and understand how we redesign health systems from the bottom up. And I think that's the work of social innovators. That's what we're here to explore today, and also to explore a little bit of the role of philanthropy. I'm delighted to see that the SIHI network continues to grow, and that the hubs in each of these countries are really growing momentum, because it is at the local level where this work happens. So just wanted to encourage and acknowledge the great work by all of these hubs. I think this was the original vision between WHO, TDR, and some of the partners, including the dear late Pamela Hartigan from the University of Oxford, who has been really a champion for this space, in seeing this movement grow. I think now more than ever, we've recognized how communities need to be owners and actors in the health system, and that social innovators are the key enablers of agency for them. So looking forward to more discussions today and listening, and thank you.
Thanks, Francois. Now I'd like to introduce our panelists, and I'll start with our three innovators, Jordan, Wei Ming, and Phyllis. Ms. Jordan Downey is from Last Mile Health Systems team, and Last Mile is really extraordinary. They are increasing access for people living in remote areas with anchor programs in Malawi and Liberia. And Jordan has 5 years of experience with the team, including 2 years in Liberia. We also have Dr. Wei Ming Tang, who's a social innovator behind Pay It Forward, and he's going to tell us about this program. He's a professor of public health at Southern Medical University and director of SESH Global, the SIHI China hub. We also have Dr. Phyllis Awar, who's the founder of the Private Drug Shops Integrated Care Innovation and a researcher at Makerere University, where she leads the SIHI Uganda Research Hub. In addition, we have Dr. Meredith Del Pilar Labarda. She is a co-lead of the SIHI Secretariat, and we'll be hearing more about that in just a minute. And she is she's a professor of medicine at the University of Philippines, Manila, and does some really exciting work on community engagement and social innovation. Finally, we have Dr. Beatrice Halpap, who heads the program on innovation and management at TDR and is a co-founder of the SIHI network. So, and you can see their lovely headshots on the slide. We can go to the next, thanks. These are just a reminder of our objectives today. We want to highlight some of the social innovations in health from within SIHI. We're going to discuss how innovators, researchers, governments, and foundations can work together to advance social innovation in health. And finally, we'll identify some of the key enabling factors and partnerships for social innovation. So now the next part of this, this is building a research network for social innovation in health, and this is talking more about SIHI as a network. So as you may know, SIHI established a SIHI Secretariat this past year with the aim to better coordinate SIHI network activities and to help build a research network for social innovation in health. Noel, could you take us through and introduce SIHI both generally as a concept and then more specifically in terms of this network? Over to you, Noel.
Okay, this is just, sorry. I think I have to, my connection is unstable, so I have to hide myself for a while. Said, as you mentioned, this is just a review. For the past two sessions, we've been defining social innovation in health, and as we said, it may be a process, a service, a product, a role or behavior, a market mechanism, or a paradigm or a policy, which is that we are using to target the challenges as the health need is being felt in the community, which is or by the people. It is people centered, and you have different actors and sectors that collaborate with this innovation. The target effect is to make healthcare delivery more inclusive, more effective, more affordable, and ultimately lead to the improved health outcomes. As we see here, um, it is people centered, it is a creative solution, and it's a bottom up and a participative approach. Next slide. SIHI was launched in 2014. It is a global network of passionate individuals and institutions advancing social innovation and health in developing countries. We are convened and funded by TDR, special program of WHO. As you have seen here in the global map, we are now scattered all over the world with our implementing partners and our contributing partners. What started as 7 hubs in 2017 in Uganda, Malawi, the Philippines, Colombia, South Africa, Republic of China, and the United Kingdom, and with partner organizations and agencies, we have now additional 5 more countries: Nigeria, Ghana, Rwanda, Honduras, and Indonesia. These are your implementing partners, and the supporting partners will hopefully we have more of them in this map soon. We share a common goal, which is to advance social innovation in achieving sustainable development goals and in improving the lives in low and middle income countries. We collaborate in 3 major areas: research, capacity building, and advocacy. So if you look at the activities of most of the hubs and all of the hubs, they are focused on this one. We do research, we do implementation research, we document the social innovations that we see in our midst. We do capacity building at the university level and at the community, and we do advocacy with our partners and the policymakers, hoping that they imbibe the concept of social innovation in health and make it also their own programs. I think that's in summary, what we are doing as a hub and what we see, what we define social innovation in terms of our group. Okay.
Thanks, Noel. That was great. And now I'd like to turn to Dr. Beatrice Halpap for a little more background and context. Beatrice, you work in the world of global organizations, and right now there are a million different innovation units in the UN, in OECD, in the private sector. So what makes SIHI stand out compared to these other innovation groups?
Many thanks, Joe, and thank you all. Welcome to everyone. So the Social Innovation Initiative, SIHI, what's the unique value of it? And SIHI is really about enhancing environment and ecosystem at the global, regional, and local levels to enable social innovation to thrive. So today we see in the global environment and regional a great funding and efforts provided to support directly the social innovators. However, when we looked around and did the studies, we realized that many innovations do not sustain more than a year, then they disappear or so. And we realized that research is needed to provide evidence and guide with this evidence the innovators to know what works, what doesn't work, and how to make it effective and sustainable, and as well inform decision makers on the impact and the opportunities. So SIHI has been established in 2014 actually to address this need, and this is its unique value. the vision is to foster an increasing number of research institutions, which are the SIHI hubs, to advance social innovation in healthcare delivery and contribute to universal health coverage. So these hubs are actually very well positioned to convene the communities, the decision maker, or the stakeholder, and embed research in innovations and build capacity, as Noel just mentioned. So this is really what makes SIHI unique. It isn't unique in a way, but it's also very complementary to the other player. And this is why we welcome new partners and collaboration to synergize our efforts and together contribute to universal health coverage and the achievement of the Sustainable Development Goals. So by joining efforts. Over.
Great. Thanks, Beatrice. That's helpful. And it sounds like the SIHI team has really gathered momentum over time, and things are shifting from Geneva to Manila, where the Secretariat's based. Meredith, could you tell us more about the Secretariat? Who's involved? How does it work? And if we could get the next slide as well. Over to
Thanks,
you.
Joe, and warm greetings from the Philippines. The Secretariat is lodged at the University of the Philippines, Manila, and we're composed of 4 people. That's Noel as the lead, myself as co-lead, Jean Barcena as communication coordinator, and Joreb as a network coordinator. So it's interesting to note that all 3 of them are in different places in Manila, and I'm somewhere in Tacloban. That's an hour ride from Manila. So thanks to this online platform, we can still work together as a team. So the Secretariat is supporting the network through first strategic and network coordination. So we help the SIHI implementing and contributing partners to collectively steer the network into the direction they desire for it to take by articulating and documenting the needs, opportunities, and parameters that they will identify. Second, the Secretariat also supports the network through strategic communications. So we try to provide up-to-date messages and materials and a consistent voice that advances social innovation in health to global and in-country stakeholders. So part of that is also updating the website. And lastly, we make sure that the SIHI Global Network is sustained and everyone is somehow connected and engaged. Over to you, Joe.
Thanks, Meredith. And you mentioned coordination quite a bit. But I mean, come on, right now we're on Zoom. We live in a boring digital world. So how do you keep things interactive and dynamic in this during these coordination activities?
Okay, that's a very interesting question. And there are many schools of thought about this. And I subscribe to the school of thought that says learning is tough. And even these meetings, online meetings are tough. That's why it should be fun. What makes for a fun online meeting? So it's not just about playfulness to overcome boredom, but more importantly, it's also to promote and stimulate out of the box thinking. So in a sense, it creates a space for creativity to emerge, which is very much needed in engagements and interactions like this. So how do we do it? We explore together many things as a Secretariat. So we try it ourselves and we have fun in the process. There's a lot of practice happening and we make sure there's feedback. So I have to give it also to the Secretariat and the SIHI Philippines Hub. So we engage them during practices. It's a collective effort. So with this new normal, we learned many things by doing and we have to do it fast. Over to you, Joe.
Thanks. That's great, Meredith. I think there's lots that we can all learn from the Secretariat and the sort of digital improvisation and sort of participatory framework that you're championing. Next, I'd like to turn to Francois. And Francois, how do you see social entrepreneurs in the enabling environment change health systems? And relatedly, why is the work of SIHI on health systems so important?
Thanks, Joe. How does it happen? I think is part of the purpose of SIHI is to actually understand that process. I think if we look over time, this weekend was St. Francis Day. I'm named after St. Francis of Assisi, and thinking about, historically there have been social innovators in our world, although we only had a term for it more recently. I think what they represented were people who changed institutions when they realized they didn't serve the real purpose of why they existed. But they changed them from the bottom up, not from the top down. And I think that's the role, as I referred to in my opening comments, around what I think the role of social innovators are. And I think at a time where we've had so much top down in global health, the critical kind of role of SIHI is to actually shine a light that there are social innovators working on community-based models of health, trying to integrate those with public health systems, not work in isolation. And for the last couple of decades, we've left that all to social innovators to try and figure out on their own how to do that. And I think the purpose of SIHI is to first understand what is needed for those models to grow. What is, how can health systems, whether they be primarily public or even private, work with social innovators? How can they be considered part of the health system? So that work requires a number of things: the research capacity, the research work that SIHI is doing, the capacity building, but also the building of collective power and collective learning and collective understanding, which is the network. So, I mean, that for me is the purpose, and I'm just excited to see, the new Secretariat really driving things, and the network continuing to expand, because that will only help to evolve our understanding, but also our collective agency.
Thanks, Francois. That's great. One final question for Noel. From your perspective, what are the key priorities for SIHI as a network? What are the sort of key issues that SIHI needs to address? Noel, I think you're muted. Sorry.
Thanks, Joe. Yeah. Based on the discussion, really, and based on the what we have started, it's really the advocacy part that we should address in our own needs in the different countries, and and hopefully learn from each other's experience. Some of us might be moving in a faster pace with in their own countries, so we might learn from them how to really involve the government and how to make our advocacy more visible to the partners at the local setting. And also as well, we we help each other in terms of global collaborations, in terms of researches that we are doing so far. Like for example, if there is a call that can involve different um, countries in the different who are in one project, like what we're doing, and Joe is really very have this links with all of those calls coming and involving all of us, and we thank you, Joe, for that one. And so, because if we apply and we work as a team with the different countries, even two or three countries in one project, it shows also the unity within the network, and also we can also advance each of the hubs, making us more visible, not only local but at the global scenario as well. So I think the key is for us to really be engaged and be open in terms of communication and in sharing what each of one is doing, because we learn from each other. I think that's what the CI network should see, that is would be to maintain that kind of camaraderie and sharing with each other. Back to
Well
you,
said,
Joe.
Noel. That's great. That's fantastic. I think it's really the sort of spirit, it's the soul of SIHI is to collaborate, like you say, and encourage mutual learning. So I think you've really hit the nail on the head there. And so for the next session, or the next part of the panel, we'll switch gears a little bit and talk about the role of philanthropy to advance social innovation. And I'm going to turn to Francois here. Francois, could you describe more about how the Bertha Foundation and the Schwab Foundation have nurtured social innovation?
Thanks, Joe. Yes, of course. Well, I think one of the things to start reflecting on is, what the role of philanthropy is, and let's do that by taking these concrete examples that you've mentioned. So, I mean, the Bertha Foundation is an interesting foundation because they are rooted in social justice and equity, but recognized, and typically we're supporting activist movements, and really saw social innovators as a form of activism, as opposed to necessarily a form of only service delivery, right? And I think that kind of expression of activism, that not only do we need protests about what we don't want, and not only do we need to advocate for what we do want, we also need to be part of designing what we do want. And I think that's part of their role, and how they did that was supporting the creation of a center at the University of Cape Town, the Bertha Center for Social Innovation, that I had the privilege of being part of for the first 8 years. And quite early on, I think, given South Africa's history, sometimes we minimize, or minimize the role of social innovation as just developing solutions, where in fact, I think that you must know, and many of the people know here, it's also about the creation of agency for ongoing engagement and evolution and relationship building, and learning as communities and citizens. And so, that concept of social innovation, as opposed to a more superficial idea of let's build, solutions to fix problems, came quite early on in the Bertha Center, partly because of that role of philanthropy, saying this is, more than we're interested in the bigger picture and what we're trying to achieve in terms of these concepts of equity and justice, and recognize that needs to be driven by local actors. And obviously doing that at a university has intent in that, the understanding of both capacity building and research, and understanding of how to do that better. And also, I think with the role of universities helps to legitimize actors. So for example, setting that center up in South Africa, which was the first center for social innovation in South Africa, dedicated center, was also to recognize that this was already happening in our country. You just needed to look, you needed to, give it a name and a label and some opportunities and a platform for social innovators to talk about their work, to talk about their challenges. So I think the role of philanthropy in that is critical, because it wasn't something necessarily, while universities, my university at the time said, yeah, sure, this is something nice we'd like to do, but we don't have the resources to do that. It's not, it's becoming an established academic discipline. It is by nature interdisciplinary. And so, so I think that the role of philanthropy in supporting the ecosystem, as much as the direct support for social innovators, is required, particularly at the early stage. And I think it requires different kinds of funders to start to see that we need to be able to help to build capacity and agency, rather than only directly fund projects, which clearly there's lots of funding needed for that as well, because there are lots of gaps left between what public service provision can do and also what private sector can do. So I guess that's the quick example of the Bertha Foundation. The other one is the Schwab Foundation. I won't talk only about ourselves, but so I've since moved, as you introduced, Joe, to the Schwab Foundation for Social Entrepreneurship, which has had, a different perspective in terms of trying to not only support social entrepreneurs directly, but really also mainstream the concept of it into international institutions, into the private sector, because of its relationship and its with the World Economic Forum. So we're a sister organization of the World Economic Forum. And our role has really been, for the last 2 decades, has been in identifying and supporting quite late stage social entrepreneurs. So those that have already demonstrated scale, deep impact, sustainability, etc. And the reason for that was to really bring the best models and the evidence behind why these kinds of approaches need the world's attention. Quite recently, actually, interestingly, we're also identifying social innovators embedded within large institutions like governments and within business. So how do we use the tools of other institutions to be socially innovative to achieve social impact? So not to say it's only the reserve of community-based actors, but that's our role. And so as a philanthropic organization, just interestingly, during the time of COVID, we also tried to pull together and have created an alliance of 60 other organizations, including philanthropy and investors, corporations, etc., supporting organizations and technical support organizations to support social entrepreneurs as some of the frontline actors during the time of COVID. And I think the point here is not only about COVID, the point is that COVID has exposed our systemic inequalities, that the work of social innovators has been filling the gaps, is about identifying challenges in access, challenges in equity, working with communities and populations that were already excluded, were already vulnerable, with minority communities. And those are the exact populations that were disproportionately and are being disproportionately affected by the COVID as both a health crisis and an economic crisis. So, so I think, obviously philanthropy has a lot of different roles, and Joe, I know you want to, I'll stop just now and allow you to take this where you want to go and where you think it's going to be helpful for the group on the call today. But I guess the one point to reflect on also is that philanthropy has a catalytic role, and it doesn't have the constraints of government funding that government funding does in terms of public accountability, in terms of constraints of particular line items, in terms of departments, in terms of who can be supported through government funding, and also the kind of innovative experimental role that philanthropic money can support that governments can't always. And obviously it has different kind of flexibility to corporate funding. And so it's a really important source of funding for the social innovation world. But also, if those of you who have been watching what's happening in the philanthropic space is also taking, it's a moment also of deep reflection and even reckoning in philanthropy around, well, what, who is funded, how are they funded, where does the money really trickle down to? All of these kinds of questions are part of the philanthropic discourse at the moment. And I do think, social innovators, and particularly in health right now, present an important opportunity for philanthropy. So maybe I'll leave it there, Joe, and you might want to take this in a different direction.
No, it's fantastic, Francois. And I think I loved what you said about this moment of reckoning for philanthropy. And even more broadly, I think COVID brings us, it's sort of like soul searching, right? Like what really matters? What do we really care about in terms of health, in terms of well-being? And when I think for some people on the call, they're very familiar with the critique of philanthropy, but for others, it may not be as, this may be sort of a new idea. Tell us more about what are some of the critiques of conventional philanthropy, and how does social innovation sort of address some of these critiques?
Yeah. Well, some of the critiques are based on clear evidence that, there's a racial bias in philanthropy. There's clear evidence of that in the US, and I'm sure, there isn't strong evidence globally, but certainly if you look on the African continent, there's certainly in the social enterprise space, there's clear evidence that impact investing goes primarily to expat organizations. So there are some trends and evidence that says, okay, these are things we need to directly address. There are other, I think, which has been coming for some time, the power dynamics between philanthropy and people who receive funds, and what is really funded, and can you really innovate, and what do you really report on, and how honest are we about reporting? All of these things are happening. I think the important point for social innovators is that there's a moment of opportunity, and we'll certainly see with Last Mile Health and others, of doing things much more in partnership with philanthropists. And I think social innovators having more confidence in knowing the context, in knowing what actually needs to happen, because of where they're situated and because of the work they do. And I think all of our social innovators, who are speaking today, that we've all learned from, have demonstrated this, and how they've worked in partnership. And so I think it's a moment of affirmation, but also self-confidence, to say, because we're from here, or because we know these communities, because we've developed relationships of trust, because we've done the research, because we're consultative, because this has been designed with people, that we need to be steadfast in these kinds of approaches, and not necessarily feel the pressure of the power dynamics that has come with philanthropy. Obviously, that's a very sensitive and nuanced discussion to have, but I think the space is open for those kinds of discussions. I think the space is also open for more collective approaches and partnership approaches. So innovators that are working directly with governments or directly with large health systems is also where the interest is. There is a large dialogue happening right now around more systemic approaches. And I think organizations and initiatives that are embedded, that have deep partnerships, that are understanding how systems work and what their role is in being catalytic in that, and particularly because most social innovators are relatively small players, how they are able to actually kind of connect to mobilize these larger institutions to actually have these greater impacts, rather than only kind of more single direct programs themselves. And so we've had years of health system funding, but that's primarily been top down through most traditionally ministries of health. And I think there's an argument to be made now around the health systems are more than hospitals, clinics, and ministries of health. So I think that's part of, I guess, what, this could be a whole conversation, a whole day on its own, but hopefully opens some space and encourages everyone listening in today. And I would just encourage to listen to the social innovators we're going to be hearing from today about how they've embarked on these relationships and built these partnerships.
That's great. That's really helpful. And you mentioned how we need to get beyond sort of the ad hoc single program thinking and think more about the big picture, not just the formal health system, but informal structures and really the whole ecosystem. What do you see as some of the enabling factors to build the partnerships that you're talking about? And on a related note, we have several philanthropies and private sector partners on the call today. What advice would you have for them in terms of engaging with SIHI or thinking about SIHI as a network?
Thanks, Joe. I think we spoke about it briefly earlier, and I think part of why the SIHI exists is in order to help shine a light and build capacity, and encourage what's already happening. So the network clearly has an important role to play in that. So clearly the enabling environment is critical. As I said, we've left many of these actors to figure this out on their own. I think SIHI also, because of the connection to TDR and the international institutions of the World Health Organization, also brings a certain legitimacy that working with national ministries of health and health systems is a critical part of this enabling ecosystem. And so, funding is clearly not the only thing that's important here. Clearly, the ability to support the individuals, the initiatives, the talent that are attracted into working in these ways, to find ways that actually communities benefit with their time and investment, and this actually becomes an opportunity for communities to also secure livelihoods out of community health as well. So I think, you know, there's lots of experimentation happening around, as you say, you know, considering the health system in its both formal and informal ways. And obviously the research component is, as we're understanding how this happens, and we learn from each other, and this is primarily, I mean, the space of social innovation has, you know, has been learned from practice. It wasn't like someone sat in a room and developed a theory of social innovation. We've been learning from practice, and we've been learning from each other. And obviously, you know, TDR has a long history in operational research and how we learn, and then how we implement, and how we, you know, have that cycle of both practice and learning while building, you know, and while the theories are helpful, it is really driven by practice and operational research. So I think that's critical, and we're in that part of the world and time of the world where we know we need to create the space for experimentation, create the space for bottom-up initiatives, but find ways to connect those into bigger systems. And that's kind of what SIHI offers, is that, you know, combination of those things. So, you know, what advice would I give to different people? I think if people are turning up today and interested to learn, there are lots of spaces to learn. I think the best way is to connect to some that you have that either connects to you personally or institutionally, or through some agenda, and the SIHI network can certainly put you in touch directly with social innovators through the hubs. I think that's always the best way to learn. And then, of course, there's a lot of information, you know, on the website, but it's really about, I guess, opening. I mean, my whole career started off, you know, as a physician within a public health system, and recognized that despite, you know, great training, great equipment, we were only, you know, we were very limited in terms of really getting to the deeper social determinants of health, and the ways in which health systems interacted with communities. I think both the Ebola crisis and the COVID crisis have exposed a lot of our structural weaknesses. And I think now's the moment to start building resilience in communities as much as in systems. And I think that intersection between the two is a significant role for social innovators. So, you know, my only advice is get stuck in, find someone to connect to, learn, engage, support something, and use that as a learning experience. And then obviously at a strategic level, there are lots of opportunities both with SIHI and the multiple partners, you know, here on this call.
Great. Thanks so much, Francois. That's really helpful. And I think we have time for one more very quick question. So sort of 1 or 2 minute answer. You mentioned very briefly the COVID Alliance before. And could you tell us a little bit more about how this is going to create ecosystems to protect vulnerable groups and catalyze some of the partnerships that you mentioned?
Great, thanks, Joe. I mean, the other recognition is that we're still somewhat fragmented in this, you know, quite rapidly maturing ecosystem, but still relatively new in the bigger time scale. So the alliances try to put together a shared agenda of the kind of significant actors who put resources behind social entrepreneurship and social innovation, and try to identify 25 concrete recommendations in something called an action agenda for the next 18 months. And really using COVID as an opportunity to support frontline actors through this action agenda, so mobilize new resources, both financial and non-financial, but also use the opportunity to come together a little bit as a sector and advocate for some of the policy changes that are required, and some of the other aspects of the ecosystem, infrastructure, architecture, metrics, marketplaces, all of those things that are growing but have been somewhat organic. And so it hopes to put a bit of a roadmap ahead, and thanks for sharing that, Joe. There are some clear concrete recommendations. There are also, you know, lots of organizations to connect to in there, and our hope is to bring new actors on. And so one example that I'll just leave you with is a corporate SAP that made a commitment to get all of its take its entire global supply chain and dedicate 5% of that to social enterprises. Relatively small, but if you think about their business-to-business supply chain platform, it has 146 million companies using it for procurement. So those are, one example of the ways in which, we could really help to bolster and mobilize the social enterprise sector. The other big angle is government procurement. If governments actually understood how to procure services and partner with social innovators, that would be a big step forward. I'll leave it there, but thanks, Joe, for this opportunity. Really looking forward to the next session.
Great. Thanks, Francois. And I know you're going to need to leave in a few minutes, but really appreciate your remarks. And I think what Schwab Foundation is doing with social innovation and social entrepreneurship is really exciting. So I would encourage folks to look at the COVID action agenda. The link is in the Zoom chat. And thanks again. So now we'll shift gears and meet our social innovators. And we have Jordan, Wei Ming, and Phyllis. And what we'll do is at the beginning, Jordan is going to introduce Last Mile Health as part of the partnership with the Bertha Center. Wei Ming will talk a little bit about Pay It Forward for gonorrhea and chlamydia testing. And Phyllis will introduce the Drug Shop Integrated Management of Childhood Illness Program on behalf of the SIHI Uganda group. And so each of these innovators will have 2 minutes, and they'll have 2 slides, and boom, 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 we'll go through. And then after these very brief introductions, we'll have time to go through and talk about and sort of ask questions and get feedback from them. So without further ado, I'm going to send things over to Jordan. And if you could take us through your 2 slides.
Thanks, Joe. Awesome. Okay, thanks so much to the SIHI team for having me here today. I'm really excited to be here and to talk to you all about Last Mile Health. My name is Jordan Downey. I'm a senior technical coordinator on the health systems team here at Last Mile Health. And Last Mile Health is a community health organization. We support governments to build and sustain strong community health systems that bring primary health care to remote and rural populations through community health workers. So as Joe mentioned, we have long-term programs both in Liberia and Malawi, where we do direct implementation in support of ministries of health. We also support other implementing partners to do health system strengthening work with sort of a lighter touch TA approach in various countries. Within our long-term programs, we have trained and deployed over 3,800 community health workers who live in the communities they serve and extend the reach of health systems by providing basic primary health care to rural and remote communities. So they provide both health promotion, health education services, as well as basic curative services for some of the most common illnesses in those communities. And then they also help link patients to facilities for more advanced care when necessary. So on the next slide, we have seen the transformative power of community health workers integrated into primary healthcare teams and community health programs that are institutionalized within national health systems. So of course, that integration is not possible without really strong partnership and engagement with all levels of government. And we also believe that this approach of health system strengthening through community health workers can be translated and adapted to contexts all over the world, wherever health inequity exists, whether it's high-income countries or low and middle-income countries. So to that end, we also partner with academic institutions as well as ministries of health to create open access courses on health system strengthening through the Community Health Academy. So far, over 27,000 learners have accessed those courses. And we're looking forward to continuing to expand that platform to really open source the learning that has made especially Liberia and other countries so successful in transforming their own health systems through community health workers. Thanks.
Thanks, Jordan. And now Wei Ming will take us through and introduce Pay It Forward. Go ahead, Wei Ming.
Yes, thank you very much. Thanks, you, Joe. And really appreciate for this opportunity to introduce our Pay It Forward project. Actually, Paid Forward is an innovative financial model for health programs. Usually when a person comes to a health-seeking facilities to seeking health service, they can receive a test or vaccine free as a gift. And we usually told them actually that this gift is someone from their community who care about them and donate this gift to them. So after that, the service, they usually ask us whether if they would like to pay another person in their community for the same service. The key innovation for this strategy is, as an innovative financial model, it is building trust and community engagement, and also strengthen community solidarity into health service delivery, especially among the marginalized people or like health service not commonly uptake. For example, we tested this among gay men in China for chlamydia and gonorrhea testing. As you may know, those two testing are usually stigmatized, especially among gay men who are usually marginalized. We tried this model among them, and we significantly increased testing from 18% to 58% as compared to the standard of care. And in our model, the vast majority of the participants actually donate some amount of the money for the other people to do the chlamydia and the gonorrhea testing. We established the financial model to be used in a low resource settings to increase diagnosis testing uptake. So next slide. This model, in this model, we usually invite and work with different communities. For example, we have the partnership with community-based organizations and private sectors to design, implement, and evaluate the programs in healthcare delivery. Besides this, we are also working with the local the governments or leveraging relationships with the governments or the STD clinics, because usually we do all this testing in the STD clinics, and in the later on, we want them to go to this STD clinics for the further testing. So we leverage this resource and usually partner with multiple resource of partners and compact them together to increase STD testing uptake among gay men. We also tried this model to increase the flu vaccine uptake in China at this moment. We see a very similar results as we did for the chlamydia and the gonorrhea testing. Yeah, that's a basic information for the Paid Forward project. Thank you.
Great, thanks, Mei Mei. Now we'll turn things over to Phyllis, and she's going to introduce the private sector integrated drugstore project. Over to you, Phyllis.
Okay, so the drug shop integrated management of childhood illnesses project. This really came up to answer a question on how can quality of care at a small private drug shop like that in the picture be improved. And this, as a way of background, at least 60% of children under 5 in sub-Saharan Africa and much of Africa as well, when they have a fever, they first seek care at a private health facility, which are mainly comprised of these over-the-counter drug shops like that. And so we came together and organized ourselves as a collaborative research initiative to engage these private drug shop owners to improve the delivery of care that they give to children. The key innovation here is that we took the integrated community case management strategy, a WHO and the UNICEF supported strategy for public sector improvements of quality of care in the community with community health workers. Took that, as Last Mile is doing, took that intervention and that strategy and introduced it in the private sector at these units where more than half of our children go to seek care. And that really contributed to exponential improvements in quality of care. For example, 90% of children with malaria, pneumonia, and diarrhea are now in almost every region in Uganda where these drug shops operate. Where at the time we have been assessing this project over the last 10 years have really been appropriately diagnosed and treated according to the guidelines that they work with. in the integrated community case management strategy. And the evidence generated from our project and over the last many years now has contributed to updating national policies for management of malaria and even the integrated community case management approach in Uganda. Next slide, please. So how have we worked with all the multiple stakeholders, and how have we leveraged these different actors in this project? Generally, the main point is that we have brought together researchers, the public sector, the private sector providers to work together to scale up the project and to really just improve quality of care. Who are the main actors that we've worked with? As I said, this is a collaborative research project. It's been heavily funded to the academic universities and institutions that are involved. Mainly our funders have come from philanthropies, one of them being a very small philanthropy like the Einhorn Family Foundation, but then bigger funders interested in these philanthropic approaches, particularly SIDA and SIDA's funding to Karolinska Institute, Uppsala University, to Makerere University itself. And so these multiple funders, we have linked them directly with our policy. We've brought funders, researchers, our policymakers at the Ministry of Health, and then the innovators themselves to work together. And as I was introduced, I lead the hub in Uganda, the Social Innovation Hub, and this is really how we work, bringing together our policymakers at the ministry level, innovators, implementers, researchers, to take social innovation or these community-based interventions forward. And that over to you, Joe.
Thanks, Phyllis. That's a really exciting program and important research that you're doing in Uganda. So now that we've met the innovators, I'd like to unpack success. And let's think about, how do we measure success? What are some of the, how do we get to, what's driving success? Jordan, your project brings healthcare really closer to people in remote areas. From your perspective, what do you see as the critical drivers of success for last mile health?
Yeah, thanks, Joe. So I think one thing that we consider to be a really crucial driver of success here is really strong government engagement and long-term partnership with the government. So community health worker programs need to be institutionalized and integrated within national health systems. So when I say institutionalized, I mean that not only are community health worker roles actually recognized and detailed in national health policies, but also that they are costed for in government budgets, that they're paid fair wages, and that they have fair working conditions. So Last Mile Health accomplishes this through several strategies, one of which is engaging with government really at all levels, at national levels and subnational levels, and also at the community level, to cultivate champions for community health, who are really invested in the community health policy and invested in the community health worker program, who will then fight for stronger community health systems when it comes time to actually make policy or to revise existing policy. One kind of related aspect, I think, that's also a really crucial driver of success is building coalitions and then using those coalitions to strengthen entire health systems versus just kind of like one, aspect of a health system or one program. So coalitions that are made up of implementing partners, as well as government, as well as multilateral institutions and funders, can be really powerful in terms of building and sustaining integrated community health systems that kind of work across all levels and sort of attack this fragmentation and siloing within health systems. So everything from integrated service delivery, supervision, policymaking, reporting, but then also for sort of influencing global norms and collaborating to obtain resources and crowd them towards the last mile. And then the last thing I think I would highlight is just the importance of really strong community engagement. So communities choose their own community health workers, and those community health workers come from and live in the communities that they serve, which means that there's a really high level of trust between the community and the CHW. And that makes care a lot more effective and a lot more patient-centered. And we really saw this, especially during the Ebola epidemic in Liberia in 2014 and 2015. CHWs were a really critical voice in educating communities about myths around Ebola and also promoting behaviors that ultimately allowed Liberia to stop transmission of Ebola. And they're playing a similar role now during COVID. So I think there are lots of crucial drivers of success for the programs that we support, but I think those top three factors, strong government engagement, coalition building to support health system strengthening, and community engagement are probably the top three that I would mention. Thanks.
That's fantastic, Jordan. Really nicely put. And I think I'd be interested to hear if you're, say, in Monrovia, you're just starting out, you don't have a big organization, but you're just starting sort of a new project, a new social innovation. How would you, what are some of the ways that you could form these partnerships with government and these coalitions, and sort of how do you get the ball rolling early on? And I'd be interested, like early in the last mile health sort of journey, what were some of those first things, the sort of first movers that helped bring together partnerships?
Yeah, I think one thing that we learned pretty early on was that it really takes quite a lot of time often to develop these partnerships, and that it's important to invest that time up front, even if it's harder to get things done in the beginning. It's important to bring everyone to the table and make sure that all the stakeholders who are involved actually have a voice. And I think, not everyone is on board with CHW programs from the start, despite lots of evidence for their effectiveness. And I think to get people on board and to build those really strong coalitions, you have to understand what each stakeholder's priorities are and what problems each stakeholder is trying to solve. And I think what we've found to be effective is, instead of trying to convince people who might not be invested in community health that CHWs are important in a vacuum, to kind of start with something that most people don't need to be convinced of. So for example, for us, that's often that universal healthcare and health equity are really important. And then focus on convincing people that CHWs are a critical component of actually achieving those goals. And I think something that we're probably all of us on the panel and maybe all of us on this call are used to hearing is that CHW programs or other health programs that we know work are not sustainable financially. And I think it can be difficult to argue against that. There are lots of problems in the world that require a lot of money to solve, but I think we've had success developing partnerships through kind of shifting that sustainability argument and convincing stakeholders to prioritize CHW programs as a cross-cutting way to get closer to achieving, or to actually achieve, a lot of different objectives within the health sphere, and not just delivery of community health services in a really cost-effective way. So like infectious disease surveillance, I think is a fantastic example and a timely example. So rather than building a really expensive surveillance system with infectious disease specialists that have to monitor an entire country, CHWs can monitor their own communities for emerging infectious diseases and alert the health system really early on. And then I think another thing that we found is that one way to convince stakeholders that CHWs are an important part of a really strong health system in that partnership development process is to show them evidence for CHW effectiveness. And so we partner with a lot of academic institutions to evaluate various components of CHW programs. And then partnerships with other organizations in the community health space have also been really transformative. So partnerships like the ones built through the Bertha Center work and built through the Community Health Impact Coalition that allow us to kind of come together and share norms and best practices, and also to advocate for resources and for shifts in global norms. I think we're a lot stronger together than we are separately. And that's also helpful in terms of collecting kind of all the global evidence for CHW effectiveness and then sharing that with funders and governments to build those partnerships on the basis of the importance of community health workers for strong health systems.
That's great, Jordan. I think it's really a nice way of thinking about, instead of if you have a specific community health worker program, the entry point may not be, here's the community health worker program. It may be, let's say we agree that UHC is an important goal, health equity is an important goal, and sort of iteratively develop a program with the government and with other stakeholders. That's fantastic. And you mentioned infectious diseases, and so Wei Ming is working in infectious diseases with Pay It Forward. And Wei Ming, could you tell us more about what makes Pay It Forward successful? Like what is making gay men more likely to receive a gonorrhea and chlamydia test in this specific project?
Well, thank you. Thanks for the question. I think there are a couple of reasons for why this program can be success. First of all, I think building community trust is the first reason. Usually, like a gay man is stigmatized or like marginalized in Chinese context, and they usually do not want to disclose their status. By using like a paid forward way and engaging community to work with them, like they usually can understand that they are cared by the other people in their community. So this can be increase the trust in taking the service. The second point is actually is also usually related to this. Through the way of community engagement and through the community engagement, they are feel like they are part of the community and feel okay. Since they are cared by the community, they also need to participate in the community events and contribute to the community. I think the community engagement is the second reason. And the third reason is actually through the model we actually build the solidarity, which generate a warm glow in the community, because they are cared by the members in the community by doing free testing to them, and they are also asked to see whether they would like to donate to others in the community. In this way, we can generate a warm glow and pass through the community. So then in this way, everyone feel okay, I'm cared and I need to care others. The other reason would be in the paid forward is an innovative financial model. It actually reduce the burden for testing. For example, for the gonorrhea and the testing project, the yearly testing fee in China's context is about 20 USD. But somehow, since we have some donation from the other resource, they can donate whatever the amount they feel comfortable to them. For example, if I'm a student, I do not have too much money. Probably I can just pay $5. And for another person, if feel okay, I'm rich and I'm care about the community, I may donate $50. In this way, the financial burden for most of the people will actually reduce. I think these are typically the 4 reasons for why gay men are likely testing gonorrhea and test chlamydia in the context. Yeah.
Thanks, Wei Ming. That's really helpful. And now moving to Phyllis, your project meets the needs of children in low-income areas. What triggered you to start this project, and what do you see as some of the key drivers of success?
Okay, thanks, Joe. What triggered us is an interesting question, but it was the huge gap that we saw in the quality of care in the private sector. That's one. But secondly, the reality that children, up to 60% in Uganda and similar countries, were accessing their care fast at the level of a private drug shop or a small clinic in their rural communities. So there is a place that children are going to seek care that was not fully regulated by the public sector, and generally nobody knew what's going on in this area. And so a huge gap that we saw, and a huge need for care at this level in the community, and a huge need to improve quality of care. So very little research or even work, interventions within this private sector level had happened before. And I'm sitting at the School of Public Health at Makerere. We had a research group, long-standing one, supported by our local researchers and our external funders, that was doing community surveys every year and actually introducing or supporting research on integrated community case management of malaria, pneumonia, and diarrhea. We're finding every, 60% of our children are going to the private sector and there's no intervention there, and yet the same intervention could benefit that level. So really a huge gap, a huge need, and a group that was able to already inherently organized and able to at least get some answers in related to the private sector. And so we took up this project, sought funding, included it within our activities, and we went straight out. So this is really how innovation, social innovation happens. Normally there's a huge need, and our community members see what's happening. Some can contribute, some can intervene, and this was the approach we took. The drivers of success and what really created success was, I think the intervention itself created the success, an intervention that can improve quality of care. So there's training for these drug sellers, use of diagnostics for malaria, pneumonia, respiratory rate counting, and appropriate medicines availed through their supply chains. Literally, this was just strengthening the healthcare provision at that level. And once that happened, quality of care improved tremendously we've done sufficient evaluations of this approach. And so going out, I think that the success is that we were brave enough, we were able to intervene, and we went ahead and intervened in an area that there was little going on. That's one. Two, the intervention itself was already a well-known successful intervention. And then once it was introduced there, results were extremely positive. The drug sellers just took up the initiative, as well as the communities continue to seek care there. And 10 years later, just 2 years ago, we did a big evaluation again through my postdoctoral work, again funded by SIHI. We went back to these drug shops that had little intervention ongoing, a little continuous intervention from the funded projects that we do. But these drug shops maintain diagnostic tests to the children and on their own. And so literally, once there is a need and an appropriate, a good answer to it, it's sustainable in itself. Over to you, Joe.
It's great. It's a great story, Phyllis. And I'd like to shift gears, but I'm going to ask the next question back to you, Phyllis. Now we're going to talk more about different engaging multiple sectors. And I know we've started into this, but we're going to sort of dive a little deeper about engaging government, engaging researchers, engaging different groups, breaking down some of the silos. And for you, Phyllis, going back to the very beginning in these drug shops, was it you finding the drug shops, or did the drug shops find you? And thinking about the very earliest part of this project, what's your advice for others who are just getting started with a new sort of social innovation?
Okay. That's an interesting question. Let's start with the drug shops themselves. Did we find them? Did they find us? We were researchers, found drug shops in communities already managing patients, managing children. So they existed already, would continue to exist with or without us. And we having so as the research groups, we were working already directly with our ministries of health, supporting research around scaling up and evidence on integrated community case management. And so already we are linked with the Ministry of Health stakeholders, and then there are these agents in the communities that are providing care. So while they were there, we actually found them there, and we went ahead to study what they do and how quality of care can be improved there. So we found each other, I should say, and then brought together the mix of the other stakeholders. So the policymakers who who supervises drug shops? It's the National Drug Authority on the table to allow them to utilize diagnostics, to utilize additional medicines like antibiotics over the counter that they were not authorized to provide. So bringing together these people, first in a pilot project, to really control the intervention and provide the evidence. So the stakeholders were, I mean, the innovators were there, the innovators, us as well, the researchers, we are research innovators, were available, working in the area, brought together the Ministry of Health, and also really looked around for funding for this further work. And so made the case to all of our funders, who were many, as I already started to mention some of them, and just as long, because we needed to make the case for the policymakers to let work happen there, and as well as to find funding to continue this work, and up to today. Over to you, Joe. What do you ask next? What more do you want me to say?
No, it's great. That's wonderful. I love it. And I think I love the innovation, and I think what you've done in Uganda to really, bring together these groups and have sort of facilitate these partnerships and do the research. I just put the quasi-experimental study reference in the chat. I mean, I think it's just so impressive. So congrats again on that. I'd like to reach into the Q&A box for our next question. Dr. Amazigo has a question for Jordan about challenges related to community health workers. What happens with community health worker attrition, demand for incentives? Talk about some of the barriers and challenges associated with scaling up this innovation, Jordan. Thanks.
Yeah, thanks. Great question. I think that attrition of CHWs is something that we see a lot in a lot of CHW programs, but I think that one of the ways in which Last Mile Health handles this is that we really believe that payment for these workers is not optional. So the incentive question, I think we like to think of it less as an incentive and more as a salary. So they're on government payroll, and they are, salaried by the government, paid by the government, just like any other government worker. And then the question, of course, is where does that money actually come from? And I think that's where it can get difficult. So in Liberia, for example, they're moving towards this model of one county, one partner. So there are 14 counties in Liberia, and they're moving towards a model where there will be one implementing partner supporting each county, and moving towards really sort of transition of the entire program over to the government, so that the government can be fully running the program on its own and paying those community health workers and their supervisors on their own. And I think it's definitely a need that we see there. And I think it's one reason why we have an entire team that's dedicated to obtaining resources for the program and doing advocacy for the program. So we have a health financing team and an advocacy team who are tasked with kind of trying to shift these norms globally to make donors aware and funders aware that, it's not optional to pay community health workers, and the world just has to shift towards making sure that financing is available for governments that want to be running these programs. So that has been a challenge in terms of scaling, but I think having a team that's dedicated solely to kind of handling that challenge has been really helpful. And the way that we currently operate in Liberia as well in terms of scaling is we started in just one county, and then we scaled to an additional county sort of during and after the Ebola epidemic, where we were able to demonstrate in the one county that CHWs were really able to continue to provide care even during Ebola, even when health facilities were closed and a lot of other workers were not, a lot of other health workers were not working. So once we scaled up to the second county, we were able to demonstrate increases in access to care as a result of the CHW program. And that was really helpful. That evidence was really helpful for us in terms of getting everybody on board for scaling up to the national program. And now we maintain in one of our counties that we started in, we maintain kind of an innovation program where we sort of test out new revisions to the program and then sort of demonstrate to the government how they work and whether they work, and then when they do work, advocate for those to be included into national policy when there's like a midterm review cycle. So some challenges often with like thinking through the sustainability of some of those innovations that work really well, especially when it comes to like adding other health worker cadres and things like that. But overall, it's been helpful to have sort of like a demonstration site where we can test things out in partnership with the local government there. Thanks.
Thanks, Jordan. And you mentioned in terms of community health workers, I think this is a key issue about who is implementing the intervention, where are they from, how are they involved and engaged. Wei Ming, could you tell us about how engagement works in Pay It Forward and who's implementing that program and how does that influence the sort of effectiveness of it? Over.
Oh, this is a really great question. I think the reason why we need to engage the committee is there are I can answer it from two perspectives. One is from the implementation perspective. The second is from the future scale up perspective. For the implementation perspective, as we know, as I mentioned before, gay men in China is usually stigmatized, marginalized, and especially hard to reach. If we want to provide a health service to them, we want them to disclose their sexual orientation to us, but they are very likely to disclose. Without the engagement of the health of the community health workers or community-based organizations, we even cannot reach them. If by collaborating with community-based organizations, they actually, since they're already working within the group in the community, and they are knowing the needs of the demands and needs of the community, so they can provide tailored, friendly service to gay men in China. So by leveraging their resource, we can actually use their ability to help us to reach the MSM and help them to provide the Pay It Forward model to them. So in this way, they can significantly, the gay men can have a strong likelihood in participating in the project. And in addition, since they are trusted the health trusted community-based organizations, they also would like to take the testing. This is from the implementation perspective. From the scale up perspective, for all studies, this is like a post-experimental study or randomized control trial. This is research, but for the future, since we have tested this program as very useful, we need to implement this program in the future. We are researchers. We are in an academic institute. We do not have enough resource to scale up the service in the later on. While community-based organizations is already providing HIV testing or other syphilis testing, as well as STD testing to the community, they are actually the right institute or right partners to work with for the future to scale up. For example, we are piloting we are developing an app for future use to implement or scale up the program. We are working with the community-based organizations again to help them to help us to develop the app and the future later on test the app in the community and finally scale up the program in the later on. Without the engagement, this will be just a research. So in the future, if we really want to make our innovation be useful, we have to engage them from the designing and from the future scale up. Yeah, that's it. Thank you.
Thanks, Wei Ming. And now I'd like to give a round of applause to all the panelists. It's really great responses, and I think the work that all of you are doing is really fantastic and exciting. There are a few questions that have already come in on the Q&A and in the chat box. Just a quick reminder, if you have any questions, feel free to put it in the question and answer, and you can say a question for Phyllis or a question for Wei Ming. So the first one I'll go to is from Dr. Rosanna Peeling, and she has a question for Phyllis about the integrated drug shop, and she's interested about preferences for people. Is there any data showing that parents prefer to go to the drug shops where you've implemented this program compared to other types of drug shops? Over.
Yes, thanks. That's a nice question, Rosanna. Indeed, within our assessments and our studies, actually very early on in the implementation of this project, what we directly saw, and actually this is now part of our recommendations, is that as soon as you train the drug sellers to manage better children, there are two things that happen. Is that actually they take even the business away from the other non-trained providers. There quickly becomes a preference for these trained shops. First, because of the skills that they have, the availability of medicines and diagnostics. But also an additional preference that we saw was that there were individual preferences. The characteristics of individuals, of the health workers, in quotes, that communities prefer. And so already there are individual preferences. For example, a health worker that really is empathetic and really takes care of their patients so much better. Already that drives patients to them. And now this health worker has all the skills and all the commodities and all the diagnostics that are needed. This really drove away patients from other non-trained, also non-registered. So there's a mix of these shops that exist. Some are fully registered with the National Drug Authority. Others are just illegally operating under the table, but they're all there in the same space, and patients go to all of them. But this really consolidated patients to these trained drug shops. And we provide this specific recommendation to the Ministry of Health that there will be a consolidation of patients to units and keep track of it, know it, and even makes training and maintaining skills much easier. You just focus on the few that eventually take up the intervention strongly. Thank you. Over to you, Joe.
Sorry, that's great, Phyllis. We have another question about community health workers from Mei T, who says, thanks so much for the wonderful presentations. Are community health workers considered in the calculations about shortages of healthcare workers made so far? And I think the second part is about sort of personnel and are there ways in which social innovation contributes to a shortage of healthcare workers and LMICs? And I would be interested also, do any of the panelists see the other way around, that social innovation could actually address some of the brain drain problems or have people be retained and stop some of the brain drain that happens? So if there's any, and I think this could really go to any of the panelists, Phyllis, Jordan, Wei Ming, do you, any of you like to comment?
I think from all my perspective, health community-based workers is really playing a big role, especially for like STI testing. As usually STD testing is stigmatized, and by by the help of from the community health workers, they actually can providing additional service to them. For example, counseling or decentralized testing. In China currently, most of the HIV or STD service are actually provided by health community workers. Many of the gay men do not need to go to the clinics for STD testing. They can just do the testing provided by the community health workers. They can also provide self-testing or self-sampling to them. So I think they directly reduce much burden from the health system. I think this also relevant to one question raised by the checkline regarding the COVID-19 pandemic. At this moment, COVID-19 pandemic impact everything, especially impact facility-based service. Within the health of the community-based workers, they can actually provide decentralized testing service, example, self-sampling, self-testing. This actually reduce the much burden for the social distancing and helping for preventing the COVID-19, and also did not reduce the quality of the service at this moment. Yeah, over.
Thanks, Wei Ming. Phyllis, go ahead.
Yeah. Okay, I was hoping Jordan would go, but this question would go first. But the question on are community health workers incorporated in the calculations about shortages of healthcare, etc. It really depends on the model that countries are using. If a country is paying their community health workers a salary or an allowance officially, these are directly counted as health workers at the primary healthcare level. And in that country is reporting of staffing or shortages. But for many programs where many countries where community health workers are volunteer, it's a bit difficult to really count them directly as health workers within the national structure. But at their local level where they exist, because they have to receive medicines anyway. These medicines, for example, in Uganda, to community health workers come from the central national medicine stores and are allocated to community health workers. And so, for example, medicines are calculated for the community health workers, for the health facilities, etc. And so the effort and the work the community health workers do does get counted directly in outputs and in really care provision at the community level, although they are not necessarily paid. Okay.
Thanks. Thanks, Phyllis. That's great. Jordan, any final thoughts on the community health worker question?
Yeah, I think just one thing to add to what Phyllis said is like when considering the brain drain issue, I think one thing that's really important is to engage with local universities and training institutions to make sure that there is actually a career path for those workers and that they're not just kind of like, even once they're salaried and paid, like continuing to provide them with training that enhances their skills and allows them to kind of move up along a career path. While staying, rooted in their communities and providing them incentives to continue to live in those remote and rural places to really be accessible to the communities that they're serving. So that's something that we're working on through the Community Health Academy is providing that sort of continuing clinical education to make sure that there is a valid career path that's available to community health workers and their supervisors.
Excellent. And the next question is from Mariam Hassan, who asked about thoughts about, can the innovators speak about how SIHI supported them to, in terms of advancing social innovation in health? Was it related to research or advocacy, or what was the role of SIHI? And who would like to tackle this one? I see Wei Ming, you're unmuted. Do you want to go first?
Oh, sure. I think, since 2014, we started to work with SIHI, and we have lively experience with SIHI, and we really thank SIHI for all the support to give us. From our perspective, I think there are at least 3 levels of collaboration or support from SIHI. First of all, since we have some innovation ideas, for example, our group use lots of things for cross-sourcing and use cross-sourcing for lots of programs. By working with SIHI, we actually developed a practical guide for the cross-sourcing, and later on we can use these tools in other areas and share our idea with others. For example, SIHI supported us to develop a cross-sourcing clinic, which help us to help others to using cross-sourcing to solve health problems. We really receive much support from SIHI. And the second thing is also relevant to this. By working with the different nodes in the SIHI community or the different SIHI hubs, we are actually conduct lots of collaborations together and have lots of programs together by using the social network SIHI created. So this also increased our interaction with the other hubs and also increased our ability to sustain our programs in the later on. Also, in the third version, I think we received much guide or support, technical support from SIHI. With the technical support and with a guide, we actually learn how to make our innovations more successful and how can be scaled up further in the future. Yeah, thank you.
Thanks, Wei-Ming. That's great. Phyllis and Jordan, I see you both unmuted. Flip a coin. Phyllis first and then Jordan.
Thanks. Thank you. So SIHI. So we are in Uganda. I lead the Social Innovation in Health Initiative Hub, and it's just wonderful. It's great that we joined this network because in our capacity as researchers in a research institution, and based on, for example, the drug shops innovation project that we've discussed briefly, we were really able to directly conduct research around an area of need, able to link innovators, link policymakers, link people just with that project. And that brought us to the attention of the SIHI network, and we've joined the network as a hub. Now our responsibility is to do the same for other innovators and innovations that are ongoing in the country. And so we focus on identifying these innovations that exist and supporting such innovators in ways that we can, which is linking them to the appropriate stakeholder that will support them. If you look on our websites, and for example, the Uganda Social Innovation page, you will find a lot of innovations that we have worked with really to understand, do some research around their project, and agree that this is a project that's worthwhile for our ministries of health to work with, or to endorse and to support. And we brought these projects to the ministries of health, and at least the work is recognized and supported in either small or bigger ways. So literally, SIHI has been a very strong catalyst really for finding additional innovations in where we are in Uganda in this case, and really for us, empowered us at the university to support these innovations even more. Over to you.
Thanks, Phyllis. Jordan?
Yeah, I think in addition to what Wei-Ming and Phyllis have already said, I think the real value add for us with SIHI was just the ability to collaborate with organizations that were doing quite similar work to us in different countries, and being able to come together and share what was working for us and work through challenges together in a way that was often more informal than it would be at, like a conference or like a formal sharing of research or programs. And I think that has been really valuable in terms of sort of like the skills-based knowledge and just the kind of know-how around how these programs are running, and how to kind of innovate on what's already there, and ways to approach government engagement and things like that. So we we're able to collaborate with a lot of different organizations through the Bertha Center throughout this partnership with SIHI, and that's been really helpful for us, including like learning visits and going to experience what's happening on the ground with other people's programs, and having others visit us to experience our program as well. So yeah, the open collaboration, I think, is really exciting.
Thanks, Jordan. And now I'd like to field a question from Dr. Obi Noir Guobioma. Sorry if I'm mispronouncing but her question is about individuals who are not able to pay for their drugs in the drug shop. So this is a question for Phyllis. How do you help folks who are not able to pay for drugs themselves, Phyllis?
Okay. Yeah, the issue of affordability is the key driver of the integrated community case management strategy, and the availability of provision of free medicines through the community health workers. However, anyway, the reality is that the community health worker programs are largely dependent on donors. So the Drug Shops project provides a slightly more sustainable approach to availability of appropriate medicines, quality medicines of a good price. So what if people still cannot pay for these medicines? So the cost of accessing a diagnostic test and medicines has been less than $1 in Uganda. And this has been really highly subsidized through at the supplier level, manufacturing companies, and all through the Global Fund, and also at least Global Fund malaria medicine subsidies that come to countries also reach directly the private sector and these drug shops, keeping the cost of the medicines very, very low. Actually, it's about $50 that families have to pay. When we were doing these projects, we got to a point when we wrote a recommended retail price. The retail price was based on our willingness to pay studies and economic assessments. How much do people really pay when they go for a consultation to a drug shop? And it's maybe a third of $1, up to $50 is what people pay. And that's what the willingness to pay studies were telling us. And so we did, unfortunately, the subsidies on these medicines are within that level. And so what we did was write recommended retail prices, really a price that we believe 70% or 80% of the communities were able to pay for that medicine. If they cannot completely pay for that cost, there's alternatives. I mean, the private drug shop and the public health facility, they just complement each other. The unfortunate thing is that medicines run out at a public health facility. Medicine there is free of charge. And patients, they just know clearly, as soon as there is no medicine in the public health facility, they just move to the drug shop. Fortunately, the cost is really affordable. And this is where we've really been able to just try to maintain a cost at that level. Not myself, but this is really institutionalized cost effectiveness. Over to you.
Thanks, Phyllis. Our next question is from Dr. Jackie Alger in Honduras. She mentions that the COVID pandemic has really placed abrupt and intense pressure on health systems. Are there lessons learned from these innovators about working during the pandemic? And anyone could comment, but let's keep it to 1 or 2 minutes each, very brief answers, and then at 10 to the hour, we're gonna do a brief wrap up. So, and in terms of order, I think Phyllis, do you want to go first, and then Wei Ming, and then Jordan? Is that okay?
Okay. So I'm just reading the question again. The COVID-19 has placed abrupt pressure, yes, on the health systems. Indeed, nobody knew, for example, what to do with surveillance in the communities with COVID-19 in our setting, for example, in Uganda. There's this disease, it's very highly contagious. We don't know unless, of course, there's a pocket of people going to health facilities. The lessons really we've already learned is that these community health workers, as well as the drug shops, well, they remain open. They remained open. They continue to provide care, and they are just a source of care provision that our communities use, and they cannot close. They're the nearest to our communities, and so this pandemic, I think, has just shown all our health systems that, at all levels, preparedness needs to be strong, or at all levels, at the community, at the facility, and that's just it. You have to. And if you have a set of people, the community health workers, already seeing 100 families every week, these people can actually do surveillance for your health facilities. I mean, for the government. Over to you.
So from us, we are in China. So typically, like we are at the beginning, we have experienced a big pandemic in China, but somehow it's turning much better since March, and actually no much pandemic, at least in the new case in China since April. But in any way, we use two ways to reduce the impact of the COVID-19 to our program. The first one we actually use is a digital approach. At the beginning, every program, or most of our program, are actually like a face-to-face personalized project. Somehow, in recent 2 years, we have switching to the programs in the way of digital. So this really helped us a lot in this year in response to these issues, because we have built lots of platforms for share of the information with the community, and use the platform to directly provide the service to the community. This directly reduce the burden of the pandemic, the impact of the pandemic. The second way is actually we start to use the way of decentralized testing. Previously, like chlamydia or gonorrhea testing was done in the clinic, but somehow in our clinical trial we started piloting in the way of do the self-sampling and the self-collection, which means we can give the testing kits or the sampling kits to the participants by shipping the kits to them, and they can since we just use the urine for testing, they can ship back the urine within the sampling kits back to us, and then we can deliver it to the lab. So in this way, the COVID-19 do not impact us too much. Yeah, over.
Thanks, Mei. Jordan?
So I'll be very brief. I think a few things that we have been thinking about and have learned is the importance of focusing. So not trying to attack every problem at once, even when it feels like there are many problems, and really thinking about your core competencies as an organization and what you specifically are best placed to support. Striking a balance between this kind of health system strengthening and continuity of PHC side, and also being responsive to the emerging needs that are occurring as a result of the pandemic. Doing advocacy to protect health workers, so especially with PPE, and just making sure that that's kind of at the forefront of efforts, because in order to continue primary healthcare, that's the only way, is to make sure that health workers aren't becoming sick themselves. And advocacy to protect vulnerable populations, so considering gender, especially in this pandemic, that's been a big issue. I think often the burden of care is placed on women, and making sure that's considered in your response. And then, of course, as others have mentioned, the importance of really strong data systems and surveillance systems, and the fact that those need to be in place before the pandemic. And it's really hard to kind of build that as you go. Over.
Great. Thanks, Jordan. And I know there are unanswered questions. There's still a few more. And for those, I think what we'll do is we'll kind of wrap up things or do a couple of final remarks. And then after that, we can come back and look at some of, and sort of go through some of the additional questions. I'm happy to stay afterwards, but I know that some folks have a hard stop coming up. So just in terms of final thoughts, thanks everyone for the participation. And I think this panel highlighted several social innovations in health from SIHI, and we saw how these innovations have been successful and how they've used a multidisciplinary and intersectoral approach, engaging stakeholders at an early stage, using community engagement methods. We've also heard about the catalytic role of philanthropies in the private sector, about how philanthropies are in many cases at a point of reckoning. And this is social innovation is a new opportunity in a different direction for folks. So I'd like to thank again the TDR for their strong support, and SIDA, which is the Swedish International Development Cooperation Agency. We're grateful for the support to the SIHI network, and thanks to the SIDA folks for joining us on the call today, and also to the whole network. So I'd like to turn over for a few concluding remarks. I'd like to have Dr. Rosanna Peeling give her final thoughts. Dr. Peeling is the chair of diagnostics at the London School of Hygiene and Tropical Medicine. She is also a co-founder of SIHI. And Rosanna, so she goes way back to the birth of SIHI and has seen it develop over time. And Rosanna, could you tell us what are your thoughts, and particularly how can we use social innovation to achieve universal healthcare and ultimately SDGs? Over to you, Rosanna.
Thank you very much, Joe. And I really am very excited that after so many years, SIHI has really flourished. Back to when we first in TDR realized that there are so many inequities in the healthcare systems in many countries, and there are so many vulnerable populations that never had a voice in anything. But we recognize that communities actually come up with their own solutions. I think TDR was one of the earliest examples of community-directed interventions in the distribution of ivermectin for river blindness. And from there, I mean, that project actually affected over 2 million people in West Africa and was very successful. And so we thought, okay, are there other examples that of social innovation that we could even recognize and maybe find a way to replicate them or help them scale up? And so in the beginning, we were thinking, okay, if we have these examples of social innovation that we elicited from around the world, how should we look at it? And so we looked at 4 different aspects of each innovation. First, do they have political buy-in? So that, as Francois said, maybe we need to be able to have political buy-in of these innovations so that we could start to build a better healthcare system from the ground up and be able to progress towards universal healthcare. Secondly, are they building social value? And I think at first we were thinking, okay, we could reduce stigma, but more than that is to build agency for the more vulnerable populations. And then thirdly, are these innovations technologically sound? And that brings to the questions that have been discussed today, both in all the innovations about the quality of the care that you bring, and then finally, are these innovations sustainable, financially sustainable? And so this to be financially sustainable is not only to allow the innovation to thrive, but also maybe to be replicated or maybe to be scaled up. And with that, I mean, we have many examples, but what we needed, and this is thanks to the funding from CEDA, we were able to have workshops to try to instill into all the innovators that research is really important for all four aspects of innovation, because with research, you could do things better and also demonstrate impact and value. And the CEDA funding to be able to have the hubs and to have these workshops really also enable the community to work together, face challenges together, and also celebrate success together. And that's what you all do so well. And so I'm really, really happy about the way everything is going. And I congratulate all of you in these innovations that have become so sustainable, and also from our last workshop made a really good contribution to the COVID pandemic response, which really shows the value of this innovation, not only of itself, but to the community as a whole. So thank you very much. And thank you to all the organizers for organizing these workshops for us to not only know what's going on, but to celebrate success together. And as we go towards universal healthcare, which is a really daunting task, maybe through innovation, we could, as Francois said, demonstrate the value of communities in being able to overcome social inequities and have social justice. Thank you very much, Joe, for asking me to give these reflections on how it's gone since the beginning. Thank you.
Thanks, Rosanna. That's well said. And just a quick final slide, many people to thank here. Thanks again to our organizing team, to TDR, to CEDA, to all the SIHI hubs, philanthropies, and partners. You can see on the left here the co-organizing institutions, the Ahimsa Fund, Foundation Mario, the Health Innovation Exchange, the London School, University of Philippines, Manila, SESH, TDR, and UNAIDS. And then on the right here, you can see our SIHI hubs. And each of those hubs has contact details on the website. So there was just a question about how do I get in touch with the Bertha Center, their contact details on the website. And then the final slide, let us know how we did. There's a brief survey feedback. It's short, I promise, it won't hurt. Visit our SIHI website. There are lots of resources online, and our whole model is very much sort of open innovation. So the crowdsourcing practical guide is not behind a paywall. We're going to be, we developed a social innovation monitoring and evaluation conceptual framework and a research checklist that'll be openly available very soon. Happy to share that with folks. For more information, please contact us. And thanks again to the SIHI Secretariat and SESH and all our partners. So I'd like to loop back, and for those who are interested in staying longer, we can continue to sort of field questions, but this will be the end of the more formal part of the presentation. So thanks. And I think the one open question that we have is from Dr. Amazigo, a question for Phyllis about policy decision makers. There's sort of a turnover within ministries of health. A new minister of health or a new person in the government may not be committed to a program. And how do you see this issue affecting scale up or sustainability of the drug shop integrated management innovation in Uganda.
Okay. All right. I mean, with policy change, it's a slow process. That's a fact. For any result to get into policy, unless it is COVID as it is, and the whole world is stuck at home, it's policy change is a very slow process. And so I don't worry so much for the drug shops project or any other. It's really what has happened is that we've had 10 years to provide a lot of evidence to our stakeholders. And once the project, once the results are extremely compelling and extremely needed, and it feeds directly into policy change. For example, these drug shops, most of the malaria care happens at the drug shop level for adults and children. And the current policy for malaria management is test before you treat, so test and treat. And so eventually we got to a point in the country when testing for malaria needed to happen at the point of care, at the drug shop, at the community health worker, etc. And so the malaria program ran way ahead with the evidence that we provided them, and of course, in addition with other evidence, and their malaria private sector management approach is that test at the drug shop and treat. So as long as it's extremely compelling, that's worked well. Indeed, a policy champion at the Ministry of Health who knew, for example, everything about drug shop, our drug shop project and drug shop integration and drug shop management, leaves the position. Of course, all the ownership, all the traction really goes down a bit, but policy should not rest on one or two individuals at the Ministry of Health. As we take forward our evidence, it's really working with the ministry from the start, as we did, engaging all the different partners, showing up at their thematic or technical working group meetings so that everybody, all the partners know exactly what's happening. And so that at a point, it gets to a point when the evidence is so well known and is so compelling. For example, the integrated community case management policy is 10 years old in Uganda, or all the implementation guidelines. And a couple of weeks ago, I get all these emails that, well, all the evidence shows towards private sector integration. We need you to participate in the ICE integrated community case management policy updates. And so the process is slow. It's generally slow for everything, for every policy change. I don't worry about that. It's just the way the process is. But there will always be a window, there will be an opportunity, and I've tried to show how to go about it. Is it work together with them, all the stakeholders from the start, keep them aware, and eventually, as long as it's extremely compelling, it will work. So I'm not worried too much, and actually we've fed into the evidence a little bit slowly, but policy change has happened and is continuing to happen in Uganda. Over to you, Joe.
Thanks, Phyllis. We've got another question. Let's see. Actually, one question from Francois that I think we touched on a little bit, but it's a really nice one that I think comes up again and again. Jean-Francois mentioned about how we have great innovations, we have great sort of individual projects, but we work so much in silos that it's not, that these are not, one part of a health system is not talking to another. And how do we break down some of these silos to forge new collaborations and new partnerships in health at different levels? I'd be interested to hear about this from all three of the panelists, really. Wei Ming and Jordan and Phyllis. Are any of you interested in taking this on?
I think from our perspective, from the beginning, we already started like collaborate with like health institutes, community-based organizations, because all the purpose of our innovation is actually to provide service to the communities through the health system. that's why we started like at the beginning to have all the engagement with all the stakeholders. I think the most important thing for engaging them in each part is, since this is like a program for everyone, that what I mean is, we are innovators, but we need to implement the program. So I think engage the all of them at every step will be helpfully very useful for later on for the scale up app. And sometimes we do have problems in in how to meeting all the needs of everyone, and this is really challenging. But somehow through the collaboration and discussion, we usually can find a way. For example, we try to collaborate with many community-based organizations, as they tend to have different needs, and we cannot meet their needs, and the community cannot meet their needs. This is a challenge we face every day. But somehow through the collaboration, I think we are on the way to find the solutions to how to working together even better. Yeah. Thank you.
Thanks, Wei Ming. Phyllis, did you have something to add there?
Yeah. Silos are unfortunately part of everyday life. Most of us don't know what happens, in the next sector. And I really see that the hubs and the social innovation initiative itself, should take on this responsibility of trying to bring the different silos together. At least we are looking from the over the tree, at the top of the forest, really looking at what's going on, because an innovator in their own field has a lot to deal with, has probably enough to deal with, that really doesn't necessarily look very far beyond their area. And I think this should be then a responsibility for us on this network to really just do the job that we're doing even better, to bring the different stakeholders together, or the different silos together, to work on a specific project. Over to you.
Thanks, Phyllis. Jordan, any thoughts on how to break down these silos?
Yeah, I think I agree with everything that's already been said. And I think it's also in some ways about kind of a global shift in the research and advocacy agenda, and moving from, once we know that a particular program is effective, moving from that to implementation research on how to actually implement in an integrated way. And I think, building coalitions that are able to advocate to funders to prioritize those integrated programs and break down those silos can be really powerful. And then when it's backed up by implementation research and evidence, then it's transformative. So yeah.
Great, thanks, Jordan. I think we've gone through most of the questions. There were a couple of earlier questions about SIHI. Is there, here's a specific project, and if someone doesn't have a SIHI hub in their country, what do they do? I do think that even outside of the countries that we work in, the hubs are happy to provide advice and discuss. So I'd encourage folks to look at the website there, and then I think these are most of the questions. Any other final burning questions or non-burning questions for folks? You can either put it in the Q&A, put the questions in the Q&A box if you have any final thoughts. No? Okay, great. Thanks, everyone. Thanks again, Phyllis, Jordan, and Wei Ming.
All right, thanks. You should let us go. Okay.
You're free. You're free.
We're free.
Thank you.
Thank you.
Thank you.
Thank you, Phyllis.
Thanks everyone for your questions.
January. 4.